Welcome to Victim to Victory, the Personal Injury Playbook, the podcast to navigating the complex legal system after an injury. We bring you the expert insights and guidance you need to navigate the legal system with confidence, help you make informed decisions, and get the compensation you deserve. Don't let insurance companies take advantage of you. This podcast is designed to empower you with the knowledge you need to protect yourself and your loved ones. So sit back, relax, and let's start exploring the world of personal injury law together.
Hello, welcome to today's episode of the Personal Injury Playbook. Our guest is Dr. Douglas Spiel, a board-certified radiologist and member of the World Institute of Pain. With over 20 years of experience in interventional pain, Dr. Spiel was the first radiologist in the United States to become a diplomat of the American Board of Interventional Pain Physicians and is committed to offering the very best in cutting-edge pain management. His unique expertise is pinpointing pain generators and offering a broad range of interventional pain modalities, making him the premier pain specialist in the New Jersey metro area. Welcome to the show, Doug.
Thank you, Lawrence.
Before we get into some of the questions, please explain how you went from being a board-certified radiologist, why you gravitated to that profession, and then what made you become involved and interested in pain management before becoming one of the premier experts in the world in pain management.
So, Lawrence, yeah, that's a good question. You know, I don't know how it is in law school, but when you're in med school, you kind of follow the guys ahead of you and the gals ahead of you. And one of my very close friends shared a lot of my interests, athlete, martial artist, much like yourself. We used to train together. He became a radiologist. And so, hey, I followed him. A couple of years into level 1 trauma radiology, I wasn't feeling like I was participating enough in patient care, and it just didn't fit me. So I started looking outside the box. And when I started looking at interventional pain, it kind of wasn't even a field around 2000. So I really started by going to weekend courses and educating myself. And it took a while till people caught on. And now it's kind of a cross-specialty field. We're seeing patients across many different disciplines, and doctors are coming from different disciplines. So we're seeing physiatrists, rehab doctors, anesthesiologists. There are a couple of radiologists in the mix, some family practice guys, and we're seeing a larger swath of physicians that are kind of making changes and changing their lives and moving into slightly different fields.
And so to break it down simply, what does a radiologist do?
Yeah, so as a radiologist, you're essentially a reader. You're a diagnostician, but you're generally, unless you're an interventional raise guy who's doing vascular procedures and biopsies and the like, you're kind of relegated to sitting in a dark room, reading MRs and CAT scans and ultrasounds and nuclear medicine studies in order to kind of elucidate, hey, what's the problem with this patient? Is there a cancer? Is there a fracture? Is there an injury? And then by and large, you're kind of giving that information to subspecialists, orthopedic surgeons and general surgeons and oncologists and the like in order to guide patients' care. As an interventional pain physician, I can still read all those modalities and comment on them and guide my own patients' care via interventional pain treatments. Pain management, 30, 40 years ago meant you were just handing people pills and patches and the like. And now we're doing interventional procedures. Some are ultrasound guided, some are X-ray guided. And depending upon where you feel comfortable, you can kind of move up and down the continuum. I do a lot of co-surgical cases with neurosurgeons, and I've worked the continuum so that even from percutaneous procedures where we're using needles to minimally invasive surgeries where we're doing keyhole incisions to somewhat larger surgeries, I've kind of moved and expanded up and down the continuum, the more experience I've had over the last couple of decades.
So when we're dealing with personal injury, what and why did you get involved with personal injury cases?
Yeah, so personal injury is kind of its own niche, and it's really interesting. If you're involved in a motor vehicle accident, generally, at least in New Jersey, you have some kind of personal injury benefits, and usually they supervene over your medical insurance. Sometimes people choose their medical as their primary, and those are all personal decisions. But these people deserve care just like everyone else. And it occurred to me after I'd been doing pain for a few years that I kind of had a very unique background, meaning that very few people were privileged to both read and treat. So it put me into kind of an unusual niche. I became kind of a Tigger. So I'm very comfortable ordering and reading studies and then acting on those studies. And then as the world has changed over the last decade, we're seeing some really crazy stuff happening. So we're seeing an expansion of a lot of the modalities that we used to use. Whereas we used to just have anatomical evaluations, which are kind of pictures and then figure out physiologically what hurts with people. Now we're having more advanced imaging that looks at physiology so we can actually see what hurts. AI is coming into radiology. So whether the plaintiff side doctor says, hey, there's a herniation, or the defense side doctor says, hey, there's not, now we can actually kind of wheel in a computer that'll digest the images and the computer will outline the herniation. So everything is changing. And if you don't have your finger on the pulse, you're going to miss things. So it's a very entertaining field and I have a huge interest in it. And every day is interesting. We get to meet new people.
Well, tell me a little bit about the next generation AI techniques, as well as the MR spectroscopy that we're using now in different cases.
So the MR spectroscopy is really cool. It's FDA approved. The company is Clarion, and they're kind of looking for their niche and how they're going to make kind of the ability to sell their wares, if you will. It's a really nice way of looking right now at the lumbar spine, which is your lower back. Frequently, that's where we see injuries. And many times I wouldn't order it because I look at an MRI and there's one herniation. It marries the patient's symptomatology. They've got back pain. It's at the L4-5 level. There's a problem with the knee jerk, or there's a problem with foot function. They've got pain going down one leg. I don't have to search for a pain generator. But other times, some of the findings are very subtle. And what I'll do is if I think the patient is a good candidate, I'll script for an MR spectroscopy. Right now, there's one imaging facility in New Jersey that houses the software for me. They'll do the study. And what I'll get is two very important findings. Number one, when discs herniate or they have a tear and they're actually painful, you can look at certain chemicals in the disc and compare them with other chemical signatures in adjacent discs. We used to do what is turning into an archaic procedure known as provocative discography. We used to stick needles in a bunch of discs and we pressurize the disc with contrast dye. We'd take pictures under X-ray and the patients would scream when it hurt and they wouldn't make too many faces when it didn't hurt. And we can use that to say, hey, this disc hurts, this one doesn't. With MR spectroscopy, we're still comparing discs within you. So maybe we'll look at L1-2 down to L5-S1, but we're specifically looking at chemical signatures. And if statistically the chemical signatures are significant in 2 or 3 discs, then those discs are termed painful. And there are actually studies out now where if you operate on a painful disc, you've got well over 90% efficacy, where if you operate on a non-painful disc, your efficacy for the surgical procedure goes down into the 50s. Similarly, the same spectroscopy unit can look at something within the disc known as proteoglycans. And real simple, there's vertebral bodies and then there's discs. These are kind of the shock absorbers in your body. And then behind the vertebral body are these paired joints known as facet joints. So kind of every level of your spine has a 3-joint complex. When we look at the MR spectroscopy of the proteoglycans, those are really the hydrophilic, water-loving substances within the nucleus, the jelly portion of the disc that holds water. And that's really important because when the disc is buoyant, it resists structural forces up and down and torsional forces because there's an outer annulus that stays intact. If you lose proteoglycan and you lose fluid, the discs degenerate or desiccate. When proteoglycan content also goes down, some of the nerves grow into the disc and can cause pain. But most importantly, if the disc loses buoyancy, The structural forces from walking, from bending, from carrying, from lifting are transferred backwards onto the facet joints. What does it mean? What does it mean for the patient? And what does it mean for the doctor and the attorney? So for the patient, it helps explain pain within the disc, but it also helps us explain pain within those joints in the back called facet joints. And if you have disc desiccation and loss of proteoglycan, the forces on those facet joints go up 5 to 8 times. So when your clients and my patients come in with facet pain, the disc has a permanent change in it, proteoglycan loss. The facet hurts. By and large, now they're both permanent injuries because I've shown loss of proteoglycan that's not getting better on its own, and changes of the forces on the facet joint 5 to 8x up, meaning that if normally your knees are carrying 200 pounds, if I loaded you with another 1,000, do you think your knees would hurt, Lawrence?
Oh, sure.
So that's kind of, as a medical doctor, we can treat the disc, we can treat the facets, but now we've come to kind of a new global understanding of why it hurts, why there's pain, and why that pain may be permanent. The AI is really sexy technology, and I'm really excited. I worked initially as a consultant, as I did with the Clarion on their product, but most importantly, the company Colombo AI that's working on the AI, they have approval. They just got approval in Australia. They've got approval around the world. And what we did, we looked at hundreds of MRIs, myself and maybe 20 or 30 different radiologists, and we graded them. We said there's a herniation here, there's a tear here, there's some disc desiccation, and we put it all into their computer system, and their computer churned it out. And now its computer system will read the images of the lumbar spine. So if you've got a decent MRI of your low back, you can pop it up into the software, and the software will generate where the curves are, where the abnormalities are, where the herniations are. It's really good for pre-surgical planning, but it's really advantageous when I want to force my point across and nobody's listening to me, and the opposition says just the opposite.
Well, as you know, we run into that in the courtroom all the time, where you'll have a defense doctor saying that there's either not a herniation or it's degenerative. So how can this new software and the new technology help you when you're trying to determine, is this a pre-existing condition or is it caused by a new trauma?
So here's kind of the art in medicine and kind of the most difficult portion. So we'll direct it to you as the patient. You're coming in for the first time. I've never seen you. I haven't seen you. Lawrence hasn't seen you. And you come into our offices and you say, hey, doc, my back hurts. And we take a history. Have you ever had back pain before? Have you ever had treatment of back pain? And very importantly, have you ever had an MRI of your low back, or has your prior injury ever required imaging, EMG-NCV studies, treatments with physiatrists or chiropractors or epidurals? And that history is powerful. For me, it's powerful because if I have a prior and I can compare the new, sometimes on an MRI, I'll see specific sentinel findings that are very specific for acute injury. I'll see inflammatory changes in a bone. I'll see tears in the disc. I'll see other things that are explained by acute change. And we can say there's a finding here that's acute to subacute. Fractures are great, non-healing fractures, but you don't get them very often. So you have to make your calls on what you see. Occasionally, there will be changes between an MRI that was done before the accident and one after, and that is a powerful clue. Sometimes you get the patient who's healthy, has had no problems, and I'm left to decide whether it's an acute injury. I look at the injury, it marries their signs, it marries their symptoms, and most importantly, I have to decide, did they have pain before? Do they have pain now? Was there a significant change physiologically? And must there be some level of change anatomically? And that's kind of important because maybe you weren't perfect. Maybe you had disc desiccation. Maybe you had bulges. But I make the analogy of the pitcher who's sailing along 6 innings, and all of a sudden he snaps a curveball, grabs his elbow, he's taken out of the game, needs Tommy John surgery. He has a tear of his ulnar collateral ligament. You can argue that the ligament wasn't perfect all 6 innings before that. But obviously, within a reasonable amount of medical certainty, he snapped that pitch, that snapped that ligament. So I'm asked the same thing when I'm on the stand. And Lawrence would ask me the very same. Doc, the patient came in. They had bulges. They were 45, 50. They competed in sports. They were hard workers. They were gardeners. They worked as iron workers. No question, this MRI, this disc was not that of a 20-year-old. Did something happen in this accident? Within a reasonable degree of medical certainty, I would say yes. And then it comes down to the patient and the client. Are you believable? Is this something that really transpired? And can you back it up with your medical history? Those are images and those are reports and treatment records that you had before you see me or before you see Lawrence.
Another important thing to do before you see a doctor or a lawyer is to make sure that your insurance coverage is optimized, especially before you get into a car accident. So I explain this to clients all the time about optimizing their insurance coverage. But from a doctor's perspective, can you talk to a layperson and tell them why they should optimize their insurance coverage?
You know, we go through this. Everybody likes to look in the retrospect, the mirror behind them after things have happened. I wish I had more life insurance. I wish I hadn't jumped on that skateboard. I wish I didn't have those last 3 donuts. But the answer is we can be a little bit more proactive. When you click to get insurance, the drop-down menu is going to offer you $1 a day, $15,000 as your policy limits. For a couple of pennies more, you can get a $250,000 policy limit that will cover you. God forbid you're in a severe accident, you've got life-threatening stuff going on, and you don't have ample major medical insurance. Because I see a lot of patients, and I'm sure many of your clients, we just got out of a pandemic. It's hard to get jobs. It's hard to pay for medical insurance. And the world is struggling. We've seen the banks collapse. We've seen all kinds of terrible things. This is at least a way to cover you when you drive. And people don't even realize it. If you're driving a motorcycle, your coverage for PIP is generally not there unless you have a very specific rider. You should at least know when you get behind the wheel and you're taking your kids to school and you're going shopping and you're driving to and from work, you've got people who depend on you. You should do the very best so that you put yourself in the best scenario. It has bearing on both how you get medical coverage and if you are really hurt, will you have some insurance that will pay you afterwards? And that's where Lawrence comes in.
It's funny you say that, doctor, because you'll have people that do not realize that they only have $15,000 in medical coverage, and for under $100, they could bring that rate up to $250,000 in medical coverage to protect themselves and their family. So I appreciate you mentioning that. And also, let's talk about an independent medical exam, which you have to deal with, and as an attorney, we have to deal with. There's nothing really independent about these medical exams. I call them defense medical exams because they're set up by the insurance company for the defense to deny a claim. So what do you do to navigate through a defense medical exam, which they try to call an independent medical exam or an IME?
So, as doctors, we take an oath, and essentially, to put it into the simplest terms, do no harm. Many people are governed by the 10 Commandments. To do no harm should really govern us as physicians. When we take on a procedure, hey, let the procedure marry the indication. You don't want to give people fusions in their back if all they have is a hangnail. So, when you're a physician, you're put into some kind of an ethical arena now. Realize that I'm a treating doctor and I'm not a defense doctor. I treat patients so that when they come in, I don't look at you as your policy. I don't look at you at anything. My mind is fixed on what's wrong. How do I make it better? And that's how I evaluate every patient. I don't know if they have representation, if they have an attorney. When I first walk in, I know the history. I know what they've been involved in. Is this a chronic injury? Is this a slip and fall? Is this a personal injury? Did this happen while they were playing baseball? I get all of that. But for me, I'm looking at pathology. When I set up kind of an algorithm of care, I generally look at a continuum from least invasive to most invasive. Sometimes I think you have a herniated disc. I may give you a measurable dose pack because you have no motor problems, no problems peeing or defecating. You're able to walk. Your pain's a 7 or 8, but I may give you some oral steroids. And if you don't have an ulcer and you don't have diabetes, hey, a week later, you may say, Doug, I go to PT, my pain's a 1 or a 2. I'm not going to treat you very much there, but I treat you according to what you need. At some point in your care, you'll be asked to go for an independent medical evaluation. Now, these doctors went to the same types of medical school that I did. Many of them are kind of under the umbrella of the insurance company. The insurance company wants to say that all your injuries are pre-existing, they're not permanent, they're not serious, and they don't merit care, physical therapy, or chiropractic manipulation, or any palliative treatments. It's your job to be honest with me and them. When you come into my office, I want to know exactly your history. I want to know what your problems were before, your problems now. Don't hide things. If you've had some drug history or smoking history or something you want to share with me, that's important in how I treat you. I had a patient in the OR the other day, and she didn't want to tell the anesthesiologist who was about to push medicine on her about the opioids she was taking and some of the other. That's not right. That endangers your care, and it engenders us not to be on your side. Now, when you go into an IME doctor's office, they're not all bad guys and gals. Some of them are really good people, good doctors, and some of them play both sides. Some of them are both defense docs and they see patients themselves. And generally, those people are reasonable. You will, in many of your travels, come across doctors who are giving you a 30-second once-over. They're going to send a huge, long, 10 or 15-page discussion of what they said to you, what they saw on physical exam, and how it lined up and how they evaluated your films. They don't scare me, these guys, because simply put, I'm honest and I read what's in front of me and I'm really good at it. For you, you're going to be threatened. Be honest with them. Don't worry. If there's a way to tape it or videotape it or bring someone else in the room with you, that's very worthwhile. It keeps people a little bit more honest. And if they're still not honest after that, that's still okay, because you've got me and Lawrence in your corner afterwards.
So what do you do if they deny treatment after the defense exam? How do you proceed forward?
You know, it's funny, and I've seen this over the last decade or so. There's been a bunch of changes, both in the way hospitals deal with us as physicians and how we deal with patients. Many times the insurance company will approve your initial treatment. You have to go through a care path. You know, they want you to go through physical therapy or chiropractic unless you have an indication that you absolutely have to have imaging first. So you'll go through your 6 weeks, we'll reevaluate you and decide what to do next. Along with that, though, even after we've seen the PT and the chiro and we've done the imaging and we say, okay, something is structurally and physiologically unsound, we need to treat it. We put a slip of paper in with your insurance company and we'll say, hey, listen, we'd like pre-certification to do, let's say something simple, an epidural injection. We want to do transforaminal epidurals at L4 and L5 on the right. You have a right central to lateral herniated disc at the L4-5 level. Your symptoms marry it. You failed physical therapy and chiropractic manipulation. You failed oral medications and steroids. The next step in the treatment algorithm is this. We're going through the pre-cert and the rubber stamp comes back and says, no pre-cert. Okay. So they'll tell you no pre-cert, it's denied for this, that, or the other reason. We may submit it again and say, okay, because of this, this is incorrect, and we're resubmitting it, and here's our proof. And we may send them some data, either from the literature or from my personal desk. And then we may decide to wait or go forward. If a doctor decides to go forward, that means two things. A, we believe you're really hurt. And two, we believe we can make you better. We also believe that if we're going to take this past the denial, there is a platform that we get paid and we can go forward on, that you are not going to be responsible for that expense. And it's called an arbitration hearing. Part of the problem with the arbitration hearings is we've got to wait 6, 8, 12 months sometimes to get a hearing, but we get our day in court. We're represented by attorneys. The insurance company is represented by attorneys, and there is an arbiter who is generally a very well-versed attorney in the personal injury arena who's willing to hear our arguments. I am extremely comfortable in arbitration hearings, and if I decide I want to go forward with your care, it's because I'm extremely confident that I'll win the arbitration. Either way, you won't have any exposure. Maybe you should speak to that, Lawrence.
That's very true. If a doctor is denied and we take the case to an arbitration, and for some unknown reason, the arbiter decides that it wasn't warranted, you will not be responsible for the payment of that bill. But 99 times out of 100, they're going to find that the treatment was reasonable, necessary, and causally related to the collision or slip and fall, whatever that case may be. So generally, it's going to be paid. There's also other avenues. If you don't have enough insurance, if you did decide to get that $15,000 in coverage and you go above that, and that's when you can give what's called a letter of protection and a lien is put on the file. Do you want to explain that a little bit, Doug?
Yeah, so liens and letters of protection, this is where you've got to trust your attorney and your attorney has to trust your doctor. And it's an interesting kind of pyramid trilogy, if you will. So a letter of protection and a lien, it essentially means that you've exhausted your insurance. You may not have any major medical insurance. You've got limited or exhausted personal injury insurance, but maybe there's some money on the other side that can help pay for your care. We're willing to take a risk as physicians that your attorney has looked at the case and said, listen, he'll call me up and Lawrence will say, Doug, there's a patient here. He or she is really hurt. They were hit by a tractor trailer. I can promise you the other side was at fault. This individual needs care. They have nothing to pay you right now. Will you take a letter of protection? And Larry and I'll get the call and I'll say, from you, I would take it any day, every day, because I know the attorney. Patient will come in and we'll give them whatever care is indicated and we'll hold all our bills. Now, if they lose their case, we get nothing. If they win their case and it's been adjudicated, they'll get some measure of money and partial payment out of that measure of money will come to the physicians and the hospitals, whoever's agreed to take the case. But in the meantime, you get back to your usual customary good health, and you don't have to wait for these things to play out over many years in order to get some treatment if you need it. And you really don't want to wait. If you've got a severe pain etiology, you don't want to take acute pain too carefree, because acute pain can turn into chronic pain, and chronic pain comes centralized in your spinal cord and your brain. And even after you fix the pain generator, you may still have pain later on. And those are the people that frequently are going for intrathecal pumps, spinal cord stimulators, because their pain has kind of been centralized, meaning that your nervous system is turning on the symptom of pain. Even if you've fixed the bone, the twisted foot, the burn is no longer there. It's almost like a phantom pain, and that becomes a real problem to manage years out. Much better to take care of things early on.
Thanks. Well, we talked about permanent injury a little bit earlier. How does the definition of a permanent injury differ in the medical community and in the legal community?
These come across my desk all too often. I can speak as a physician, and maybe you'll speak it as a attorney. As a physician, we want to look at the skeleton and all the anatomical tissues, and whatever the pathology is, will it function as it did before after healing. Will a disc tear and herniation ever function as it did before? Never. How about a fracture? Well, with fractures, you're looking at step-offs. Will the fracture line heal normally, or will it heal abnormally? Will the fracture extend into the articular space, maybe where there's a ball and joint socket, and lead to further osteoarthritis? So as a radiologist, I have to look at the type of injury, what is the normal healing pattern, and what is to be expected post-op, post-healing, post-treatment. And then as I look at that, how will that bear on the skeleton, as you will, and physiologically, how will that play out? Will that beget more pain? Will that beget more loss of function? So I'm looking at how you're built and how that transfers to the future. Will it be different tomorrow than it was the day before yesterday when you got hit?
And then in the legal community, we have to deal with the statute that says a permanent injury is an injury that has not healed and will not heal with future treatment, which becomes very difficult to overcome. So along those lines, why is it important to choose the right medical professional and the right attorney? And how should a victim of a personal injury go about choosing them?
You know, it's the hardest thing, and we've been in the field for many years, and, you're not always rewarded for your intelligence. Frequently, people go to whoever markets more vehemently. And, as bright as Lawrence is in court, most of you will never get to see that. So a good attorney is great in court and also great with his clients. A good doctor should be great with his clients first. I guess it's an added bonus if that physician is also a terrific litigator and will work for you in court so that they don't get beat up by the defense when they're being asked questions about your care and your treatment, your injuries. To me, I think you should look for excellence, at least in a physician. Certainly you want people who are board eligible, but right now everyone's board eligible or board certified. You want to know what their backgrounds are. Many doctors have different backgrounds. And as we said earlier, there's kind of a blanching in your backgrounds when you're doing interventional pain. If your only injury is a hand fracture, hey, go see a hand surgeon. If you've got spinal injuries, boy, I'd love to see you first, because there are a lot of things I can do throughout the treatment algorithm. But again, look for a specialist that is keyed into what your problem is. When you're looking at an attorney, look at the guy or gal who settled a lot of cases, has a reputation. Physicians also live and die by their reputations, not as much as the attorneys. It seems that the attorneys are a little bit more front and center. You can see what they've done in court. You don't always get to see my successes, and that's because we have some HIPAA requirements, and that's the way life is. You can always ask friends and family, who have you treated with? Were you happy? Did you have a good outcome? And those are probably the most powerful instruments for you to decide your care and who's going to handle your case for you.
Now, based on all of the information you've given us and your experience, you've talked about care paths, algorithms. When a person gets into an automobile collision, can you take us from that moment when they were getting in the ambulance to go to the emergency room throughout the entire process? What type of doctors they'll be seeing, what types of providers they'll be seeing, what they could expect in medications, and how long this will take on average. And we know every case is different, but just to give an overall outline and background about the medical treatment through the legal process.
So first things first, Lawrence is an exceptionally good lawyer. I'm a very good physician. Don't ask me legal questions, and try not to ask him too many medical questions. So here's part and parcel to that. When you're a patient, and I've unfortunately been on the other side of this, I think Lawrence has too. We've been patients. It is no fun to be on the other side, but what you have to remember, even in that scenario, you're the patient. So there has to be some trust. If somebody comes to you and you're at the side of the road and you've got neck pain and you can't move and they want to take you to the hospital, and you're like, nah, I got to drive home, my kid's got a baseball game, please trust the medical professionals around you. They know that you can have a spinal cord that's unstable, a neck that's unstable can lead to a spinal cord injury if they don't put a brace around you and put you on a board right away, even though you can move when you're still behind the wheel. An unstable neck can do that to your spinal cord. Listen to the specialists that are taking care of you. They're going to bring you to the ER. Unless it's a mild fender bender and you can drive yourself home and you feel absolutely structurally okay, defer to them. When you go to the ER, most of the people in the ER are looking for life-changing injuries. They're looking for broken bones, huge discs, which means you can't pee, you're incontinent, you can't walk, you're weak, or they're looking for signs of concussion, spinal cord injury, brain bleeds, really serious pathologies. If they clear you, it essentially means the ER doctors looked at you. You are not a danger to walk out of the ER. You're physiologically and neurologically intact, and it's reasonable for you to follow up with another physician outside. Now, there will be times when, for one reason or another, we as physicians, we're working in the ER, we make a mistake. Listen to your inner sense. If you ever walk out of the ER and you feel impending doom and something is really wrong, go back. I've had friends that have gone back to the ER with bursted appendices. I've had people that have gone back to the ER questioning the initial diagnosis with aortic injuries, things that would have been life-threatening, something said to them. God and one of his angels came to them and said, go back inside, and that saved their lives. Let's get to the point the ER discharges you. You're doing well. They've given you some meds, maybe some pain meds, maybe a muscle relaxant, maybe a mild pseudo-opioid, but you're essentially structurally intact, physiologically intact, not a danger. You're given a few days, follow up with the doctor. Some patients choose to go to an attorney first or a doctor first, both reasonable based on what you're going through. Once you get into one of those offices, they'll do a new intake. Now, as an interventional pain doc and as a radiologist, I'm going to look a little bit differently than the ER did. I'm not looking for what can get you out the door the first day so you're no longer my problem. I'm looking for what is really down below the hood. But there are some limitations. If I'm going to do an MRI, I can do so within the first 10 days if I think it's empirically indicated by what you're presenting with. If not, I've got to have a really good reason after the 10th day. You got to have a foot drop, weakness, intractable pain that you can't go to rehab, PT, or chiro. So essentially, if you come in after 10 days or before 10 days and it doesn't look like you're really structurally unsound to me, then I'll send you out for palliative care. I may give you some meds, and I'll put you into either physical therapy or chiropractic manipulation. That's part of the care path. You'll come back. Now we're 6 weeks in past the first time you've seen me. Now, if I think you're still having pain and not getting better, I may get imaging. I get the x-rays earlier, but additional cross-sectional imaging, like MRIs or CAT scans, I generally wait. If things are very bad, we can always negotiate a price for you to get something as a self-pay. But through your insurance, you will get essentially paid MRIs if indicated. You'll come back with those. Now it's another couple of weeks later, maybe 3-4 weeks later. Now we're maybe 2 or 3 months into your care. I have positive MRIs. I have your symptoms. You've been through palliative care. I look at your symptoms. I look at the possible pain generators, and I may start a treatment algorithm. Those algorithms can involve discs, facet joints, nerve blocks, epidurals, medial branch blocks, radiofrequencies, neurotomies, spinal cord injuries, surgeries. Depends on what you're presenting with as to what you get, and your treatment may go for a fairly long time. We have patients in treatment well over a year or two. So the question is, what hurts worse when you present? So you'll tell me, I may have scanned your neck and your low back. Your neck is a 10, your low back is a 6. Neither one is neurologically affecting you to the point where you're weak. I can go where your pain is. So we may start here, progress there. Again, we're going to be guided by you. We will refer out to people and specialists that you need. I may refer you an orthopedic surgeon for your torn rotator cuff if I've gotten that imaged and treated. Maybe you have a problem with your hip. So these are ortho physicians that'll see you. Once in a while, we diagnose something inside your belly. You may see some type of a general surgeon. So based on what else is going on, we may refer you to other subspecialists, and then we'll go from there. You're going to basically enter an algorithm from least invasive to more invasive, and a lot of it is not always indicated by what your signs are and what your exam findings are, but what your symptoms are. So if we do an epidural and you come back and your pain goes from a 9 to a 2 and you feel great, that's a lot different than somebody that says, my leg is still aching, I can't live with it anymore. So we're guided very much by the to and fro and the back and forth that we have with the patients.
Dr. Spiel, is there anything else you would like to inform a victim of an injury about the personal injury realm?
I think you have to realize that you have rights and you have insurance, and you're due treatment. And you shouldn't be at the whim of the insurance company that tells you you're not hurt or you don't deserve treatment. You're a patient like anybody else. It doesn't really matter how you're injured. You're injured, you deserve treatment. You deserve representation, and you deserve to see a doc.
Thank you, Dr. Spiel. Always
Thank you, Lawrence.
Great seeing you again.
Always great.
Thank you for tuning in to Victim to Victory, the Personal Injury Playbook. We hope you found today's discussion insightful and helpful as you navigate the complex legal system. If you or someone you know suffered from a personal injury, don't hesitate to reach out to us at 1-800-489-0004. Our team is here to help take you from victim to victory. Remember, taking legal action after a personal injury is a critical step in protecting your rights and securing your future. So don't wait. Make the call today and let us help you fight for the compensation you deserve. We'll be back next week with more expert insights and information.
This podcast is intended for informational and educational purposes only and should not be considered legal advice. The content of this podcast is based on the laws and regulations of the United States and may not be applicable in other jurisdictions. Additionally, any information shared on this podcast is not protected by attorney-client privilege or any other type of confidentiality. Remember, this podcast is for informational and educational purposes only and should not be considered legal advice.